Well, welcome to this very exciting webinar on how 4 different countries put a reduction of adolescent pregnancy and childbearing on their national agenda. My name is Karin Weiss. I'm project lead at Medicus Mundi Switzerland, and Medicus Mundi Switzerland is a network of nearly 50 Swiss NGOs working in international health cooperation. Despite the remarkable progress on various aspects on adolescent, sexual and reproductive health and rights, including teenage pregnancy, we still face a lot of challenges today. Especially with the consequences of the pandemic, teenage pregnancy rates have gone up in various countries. NGOs were the first to respond to these challenges of adolescent pregnancies and childbearing in the past. Their project and research studies by academic institutions have shown that adolescent pregnancy and childbearing can be reduced through tailor-made interventions. Overall progress in reducing adolescent childbearing has been slow and uneven. There is evidence of successful approaches to reduce adolescent pregnancies and childbearing from projects, but few examples of large-scale and sustained programs. So that's why we want to showcase today 4 different countries. We want to hear about their success stories, and we also want to hear about their challenges. And we will start first with England. But before I hand over to Alison Hadley, the director of the Teenage Pregnancy Knowledge Exchange, I would like to make one announcement that you please feel free to use the chat box for all your questions you may have. The speakers, they are told to interact with you in case we cannot address your questions during the Q&A session. You all received also the program in your last email. This is all in the folder, so you can access it there. And I can already see that you're already using the chat box, so welcome to this wonderful webinar. I would like now to hand over to Alison. It's your turn now. Thank you so much to be here and to present.
Thank you so much, Karin.
Interesting case on England. Thank you.
Thanks so much, Karin, and really delighted to be with you all today and to join the participants. This is the introductory slide, is a little bit about me, but we won't dwell on that. I think we'll move straight on to the body of the presentation, Chandra, if you can move that on. So I'm going to be talking about England's experience of our teenage pregnancy strategy, very much in brief, and there will be information at the end about where you can learn more detail. But the next slide just shows you where it all started. England had had very high rates of teenage pregnancy for a very long time, dating from the 1970s, 1980s, and there had been various government initiatives to try and reduce the rates, but they'd only focused on the health sector, and they'd had no significant impact. And there'd been strong advocacy all through the 1990s from NGOs and from professional organisations that government should take leadership on this and develop a comprehensive strategy. And our window of opportunity really was when the Labour government came into post at the end of the 1990s. And they repositioned teenage pregnancy as a key issue of inequalities and social exclusion that had impact through generations, and it required multi-sectoral action. And they developed a strategy for a 10-year strategy with a very ambitious goal to halve the under 18 pregnancy rate. That was any conception, whether it ended in a birth or an abortion, and also to double the proportion of young mothers in education. And to signify the priority that government was giving it, it was launched by Prime Minister Tony Blair in 1999. It was scaled up from the start. It was a national government programme aimed at improving comprehensive sexuality education in schools and in community settings, but linked also to youth-friendly contraceptive services. There was a communications campaign and also dedicated support for young parents. And it was a national programme, but very importantly, it was delivered by local government through multi-agency partnerships. Next slide. And this map of England shows you the 150 local government areas in England, and each of them had an agreed teenage pregnancy reduction target. And they were given a small amount of money each year, and they had to appoint a teenage pregnancy coordinator to lead their strategy and to establish a partnership board with health, education, social care, NGOs. And they were charged with delivering that multi-agency strategy over the 10-year period. But importantly, they were supported by 9 regional coordinators and a national government teenage pregnancy unit where I was working at the time. And I think a very essential part of the strategy was that we had to appoint an independent advisory group of experts to monitor progress and advise government. Next slide, Chandra. So maintaining momentum of the 10-year programme is really quite a challenge, but we had very accurate data that allowed us to closely monitor what was going on in the local areas. And halfway through the strategy, we did a review because we knew that some areas were progressing much better than others. And we found that the areas that were applying all the strategy actions were reducing their rates, and those that were only doing some of them or not making much effort at all were not making progress. And government ministers became directly involved with the areas that were making poor progress, and that really helped accelerate the actions they were taking and get us into a much better position halfway through the strategy. We did have some opposition, but we had very, very strong support from NGOs and from medical nursing organisations. And the independent advisory group of experts assisted ministers in responding to the challenges we got, and sometimes the negative media reporting. And some of these will be very familiar to you. So one of the common things was comprehensive sexuality education is dangerous for children. You shouldn't be giving contraception to younger teenagers. And the other criticism was that the strategy was making initially very slow progress. So the typical headlines were government introduces sex lessons for 5-year-olds, but others were, the disappointing fall in teenage pregnancies is the result of a shocking failure of policy. And the independent advisory group gave ministers the confidence to hold their nerve to see the strategy through. So that was a really important lesson to learn. Next slide, Andrea. So the results, this is fast forward over an immense amount of work. The latest data we have is for 2020, and we've seen overall a 72% reduction in the under 18 pregnancy rate. So in number terms, that's 41,000 under 18s getting pregnant in 1998. That's now down to 12,000. And all the local government areas are showing reductions, including those that made very slow progress at the start. And encouragingly, because this was a strategy really aimed at inequalities, we've seen the biggest reductions in the areas of highest deprivation. We saw a doubling in the proportion of teenage mothers in education. And very importantly, aside from the rights-based approach to the strategy, we found that it saved money. So for every £1 spent, an estimated £4 was saved on health, education, social care and welfare costs. Next slide, Chandra. So the key success factors. So I've named 6 here. So the first one was the decision of the government with the advocacy support of NGOs to reposition teenage pregnancy as an issue of inequalities and social exclusion that required more than just health to address the issue. So it required collective action. So that was really important. The second lesson was having the structures, having a national unit, having regional coordinators, having local coordinators in place throughout the course of the strategy to maintain the momentum and keep it on track. And also to have the independent advisory group advising and holding government to account. And every year they published a report on progress which had to be presented to Parliament, and government had to do a response. So that was very important. Third one is having a credible and evidence-based strategy that everyone supported. So the NGOs were really pleased the strategy was there. Medical and nursing organisations, academia all supported it. So that was a very good support for ministers. The fourth one is having a very clear target, having national and local goals and really good data to regularly review the progress. If we hadn't had the data, it would have been much, much more difficult. The fifth success factor is that we tried to embed the strategy in all the wider government programmes aimed at improving maternal and child health, aimed at improving educational attainment of girls and economic outcomes and better jobs for young people. And the last one, which is very important, I'm sure will resonate with others, is having national leadership throughout the 10-year programme, and also beyond the strategy. If we hadn't had that leadership from ministers, from NGOs at a national and local level, it would have been very difficult. And allowing sufficient time to bring about change. And the next slide, Chandra will show you that at the beginning of the strategy, it took us some time to make progress. So the first half of the strategy, the rates were coming down, but really quite slowly. And it wasn't until the mid-strategy review and things really started getting into place that we saw that accelerated downward trend. If it had been a 3-year strategy, a 5-year strategy, it wouldn't have worked. So having a long enough time to implement it was really important. And the next slide shows that after the strategy ended, the calendar year of the strategy ending was around 2011, 2012. What we did was we issued new government guidance. There'd been a change of administration from a Labour government to a coalition and then a Conservative government. But we issued new government guidance using exactly the same evidence base for the strategy to local areas. And we gave them guidance and a self-assessment toolkit so that they could assess how they were doing and address any gaps. And importantly, we continued the advocacy. So the NGOs continued the advocacy to finally make CSE, comprehensive sexuality education, compulsory in all English schools. So the period after the strategy, there was a lot of work still going on. And the next slide. So the decline is continuing, but there is a lot to do. We still are slightly out of line with Western Europe with our rates around teenage motherhood. And we've got inequalities persisting between local government areas and between individual young people. And although we have far fewer teenage mothers now, we find that they have increasingly complex needs and the outcomes for them and their children are remaining disproportionately poor. And we also know that without effective implementation of our compulsory CSE, we will not see the impact that we need it to have. So the next slide shows us what next for us. Very much continued advocacy, and you'll have heard the advocacy run through, before the strategy, during the strategy, and after the strategy. The advocacy to ensure that that comprehensive sexuality education, which is now in legislation, is properly implemented with trained teachers. So that involves parliamentary engagement, professional support, NGO collaboration, and the Sex Education Forum, which is a collaboration of organisations championing young people's rights to high quality CSE, does an annual poll with young people to monitor their experience. And on the right hand side, you'll see some of the things that young people said on our last poll at the end of last year, what more they want from their CSE. And the other issue we're focusing on is looking at inequalities. I think if we get the CSE right and the contraception access right, that will help most young people, but we have to be very careful that we don't widen inequalities and leave a small group of young people behind. So really making sure that those who are not in school, not in education, who are already disadvantaged, receive high quality CSE and access to contraception, and that those who choose young parenthood do have dedicated support. And my last slide just gives you some information about where to get more detail of the things that I've rushed through in great brevity. So Chandra, if you could just move on to that, that will hopefully show you where to get more information. Yes, so a book that Chandra and I put together, documenting exactly what was done in the strategy, but more information from myself at the Knowledge Exchange or from the Sex Education Forum. And please do email me afterwards if you have any follow-up questions we don't deal with today. Thank you so much.
Thank you so much, Alison, for these wonderful insights into the case study of England. Before we go into the Q&A, I would like to move first to Ethiopia, and we will hear from Lamesa, who is the team leader, Adolescents and Youth Health Research Advisory Council at the Federal Ministry of Health of Ethiopia. And I'd love to hand over to you, Lamesa.
Thank you very much for having me in this important webinar. So this is introductory, who am I actually? I don't want to stay much on it. Would you go to the next slide, please, Dr. Chandra? So I want to share with you reducing adolescent pregnancy. This is an Ethiopia case study. Actually, it is compiled by me and also a team from LC, Aquara, independent expert from WHO as well. Next, please. So to give you a little bit of introduction, following the ICPD, Cairo 1994, and to achieve Millennium Development Goal in the Sustainable Development Goal, Ethiopia took bold efforts to address the needs of adolescents and the young people. To address that, the Ministry of Health of Ethiopia realized that adolescent pregnancy contributes to a substantial portion of maternal deaths. And the Ministry of Health again dedicated to ensure that adolescents and the young women should be addressed in efforts to reduce maternal mortality. So adolescent pregnancy was put on the national agenda. That was within the context of the Millennium Development Goal. The Ethiopian government targeted maternal and childhood mortality reduction in rural areas where over 80% of the population actually reside. And the Federal Ministry of Health set out to delay and space childbearing through improving access to and uptake of contraception and to reduce pregnancy-related mortality. The government also put in place complementary measures to prevent childbearing, among others. How the scale-up was planned in the case of Ethiopia? The Federal Ministry of Health of Ethiopia launched an ambitious health extension program. The health extension program was set out to deliver health education in the basic health services in the community, and to strengthen linkage to health facilities, and to empower rural households to take responsibility for producing and maintaining their own health. So how was the scale-up managed? A multi-level system was put in place and supported with data-driven planning and the management. Over 5 years, nearly 35,000 health extension workers, mostly women, except in pastoralist regions, were selected by communities, were recruited and trained as a new cadres of salaried healthcare workers. Then mid-level healthcare workers were trained in large numbers, again to provide midwifery and the neonatal and emergency care services in newly constructed health facilities. A core team, including technical experts chaired by the State Minister of Health, reviewed progress, set priorities, and developed plans. And when problems were identified, again, they were managed at a higher level as well. Okay, next, please. How support was built and the resistance addressed in most of the activities. The Federal Ministry of Health worked to build and sustain partnership at national and also local levels. At the national level, the government forged partnership with professional associations of public health and clinicians. At the local level, government engaged workers from the communities they would serve in, who were aware of the context and were again trained. And then the government supported them to engage in dialogue to challenge norms such as low utilization of contraception, low maternal health service, among others. Next, please. How was sustainability addressed in this regard? The federal government used legal, financial, and management levels to ensure shared ownership and the sustainability. What are these? The government formulated laws, granted free maternal and newborn health services in public health facilities, and the government also liberalized the law on providing abortion care in specific circumstances. The government also decentralized management and the financing of the health extension program to regional and the district levels, thereby creating local ownership. Salaries for extension workers, rehabilitation of health posts were also given to the local government authorities. Next, please. So within what were the achievements with these government-led interventions? There are some changes that observed in child marriage and adolescent pregnancy and the modern contraceptive use among adolescent girls of 15 to 19. These were the results that could be obtained from a supplement that was just published almost a week ago. 8.8% percent point decrease in child marriage between the period, and 33.5% reduction again, percentage increase. This is an increase in modern contraceptive use among married adolescents, and 7.8 percentage point increase in postpartum family planning use between 2000 and 2016. Actually, the percentage point decrease in childbearing is very marginal, only about 3 percentage point decrease between the period, because when they marry, usually there is a traditional expectation to prove that women should get pregnant to prove her fertility is one of the cultural challenges that we had in local communities. Next, please. So another result that was observed because of that national government-led intervention is increase in antenatal care, increase in stillbirth attendance, and the safe abortion care by adolescent girls in Ethiopia observed it. Almost, if you see this graph, then the left side, the antenatal care and the stillbirth attendance of adolescents is almost very steady until 2011, but there is a sharp increase that was observed at least post 2011. So it is around an encouraging result. And the abortion, safe abortion use by adolescents is again higher compared to any woman of reproductive age. So this is an encouraging result that is observed. So the adolescent actually about 64% actually use safe abortion survey compared to women of other age groups. So this is an encouraging result that was observed. Next, please. So what we can conclude, the Ethiopian government took bold initiative to improve adolescent girls' access to contraceptives, and the government developed evidence-based strategies, again grounded in supportive national policies. Government committed adequate resources and managed implementation effectively, and the government again engaged in the sustained engagement of relevant government bodies at different levels, like NGOs, professional associations, to ensure access with accessible, acceptable, and accept standard of quality care actually. Next, please. So to at least to sustain the gains or the encouraging gains that we already achieved, and to increase the adolescent health, the sexual reproductive health in the future, what needs to be taken by Ethiopian government or the Ministry of Health at large? The Ethiopian must again make full use of the existing political support for adolescent sexual reproductive policies in the programs, and sustain this support in the next stage of strategy development, while working to increase social support. Again, the ministry or the government should again efforts to challenge and change social norms affecting adolescent sexual reproductive health and rights must intensify by engaging religious and community leaders, parents and the families, and adolescents themselves more effectively or more actively, including again through community dialogue, traditional values that negatively affect the health of adolescents, particularly that of girls. The Ethiopian government again must strengthen investment in and the financing of intervention to meet the sexual reproductive health needs of adolescents. The government again must continue to ensure its strategies are evidence-based and extend the availability of age disaggregated data on sexual reproductive health and rights. In line with the COVID-19 again pandemic, it will be particularly important again for the government to keep an ear and eye to the ground to understand how COVID-19 and the response put in place to address COVID is actually impacting adolescents, and address their needs with the responses that are sufficiently flexible to remain relevant and appropriate as the pandemic evolves. And much of the evidence that were generated and that put in place to substantiate the achievement so far are already published in an Ethiopian case study and also in an Ethiopian supplement that is already published almost a week ago in adolescent sexual reproductive health right in Ethiopia, that is reviewing progress in the past 20 decade and the achievement forward. So I encourage you to read those resources, and thank you very much for having me. And you are welcome with your comments and questions and the pointers during question and answer session. Thank you very much.
Well, thank you so much, Lemessa. Let me put us all now for the Q&A. Before we go and enter into the Q&A, I just wanted to say to everyone, we will certainly hand out the handouts and send it out to everyone, and also the links to relevant publications so that you can easily access all the information and evidence which is available. I have a first question. I can already see that the questions are coming in. And I would like to first have a question for Lemessa. Ethiopia made huge progress on tackling teenage pregnancy, and it's actually a wonderful example because despite all the challenges you have in your country, you still were able to go ahead and tackle the teenage pregnancy, while others areas are still under progress. Today you face political challenges, so what is feasible at the moment?
Thank you very much for the question. Yeah, the gain that you are discussing about is a gain actually observed in the last 2 decades. There may be some pitfalls in some of the programs in some of the regions because of some conflicts or other challenges that are posed by COVID itself as well. So that should be actually observed in the times in the years to come, or else the achievements that were recorded were already proven. And that is remarkable, and that is encouraging. That actually calls for next action actually, that we need to build on the success so far in the plan for the next, taking into the consideration the challenges the world faced, COVID in total, and that of maybe some local challenges as well. Thank you very much.
I'm sorry to interrupt. Lemessa and Alison, can we have your camera so that people can see you now? If you have trouble with the bandwidth, then you can cut your line. But now it will be nice. And Lemessa, you need to...
Great. Now I did it.
Yeah, great.
Thank you. Any other point that need my intervention, please?
Yeah, there will be more questions coming from the floor. First of all, I would like to hand over now to Alison and ask her, how transferable is the UK experience to countries like Ethiopia, for example? What are your thoughts?
Yeah, thank you for the question. And Chandra and I have spent much time kind of thinking about what are the transferable lessons. And I think the transferable lesson really is actually finding your moment and finding the hook to address the issue too. So in our country, it was like the issues of intergenerational inequalities, which had impact on both the young parents and their children. But in other countries, it might be keeping girls in education, it might be very high infant mortality, maternal health issues, finding the hook that gets the government leadership engaged, and then developing the evidence-based strategy that's going to address that. So you have to be quite clever, I guess, to find out what is the priority for the government at the time and piggyback that to get the agenda there. The other thing I think is really important is having a collective advocacy from all those, so NGOs, but also I think from high-profile medical nursing organisations, which government ministers may sort of particularly trust. So if you have a public health, high-profile public health person saying why this is important, really important to do that as well. And I think probably having the nerve to have a longer-term strategy. I think Ethiopia was sort of 5 years, was it, in Ethiopia, or maybe a bit more than that. But these things cannot happen overnight. They have to be sustained, and there has to be a goal, and it has to be done at a local level as well as having national leadership. If it was a strategy that was at a national level, published, and someone read, but there was no strategy for implementation, you would not have the impact. So having that local implementation with the structures to support it and enough time is really important. And I think you can transfer over different changes of government. We found that when the Labour government ended their administration in 2010, pretty much at the end of the strategy, but actually when we talked to new ministers and we said, this strategy is working and it addresses child poverty, it addresses maternal health, it addresses education, they surprisingly said, okay, I think we should carry on with it, which isn't usually the way that governments work, but actually it had shown its impact, and we convinced them that actually the things they wanted to address, the strategy would help with.
Thank you. Would you like to comment, Lemessa?
Yes, sorry. So that's right. Usually the strategy also, the Ethiopia also applied this local ownership is one of the key strategies that actually worked well. What does the local ownership means? The extension workers were recruited by local government. They will be trained and returned back to the local area where they are familiar. So that actually worked well, and that also contributed to the sustainability of the program, among others. So the government at the district level, the government at regional level, or actually on the programs, when they involve, it is easy to generate local resources and then sustain and maintain the services beyond the project periods, or even more than that. So there is local support and the funding. Thank you.
There's another question for you. How do you see the link between female adolescent school enrollment completion in Ethiopia and the employment of female-only community health workers to deliver the HEP program?
Yeah, why the program actually enrolled only female adolescents in most cases, except the pastoral regions, is that females, most of the time, the maternal and contraceptive use issues are very much sensitive topics in the community. Mm-hmm. So if the females are under the services are also uptaken by females themselves. So for the counseling, for ease of communication, for societal acceptance, females were best fitted. That is why the program selected. These students are female health extension worker providers are actually those who have completed high school and also at least 1 year training, 1 year, minimum of 1 year training for the program purpose itself. So this doesn't have any impact on school completion or school attendance because they already completed. They are encouraging other females of their age and also women who are already married in order to use contraception and in order to space childbearing. So this is why the program already recruited and they became also successful, because the service is also so women sensitive and culturally sensitive. Women are selected to do that role. Thank you.
And I think many countries will be very interested, not only in Yemen, but there will be other countries interested. How do you overcome cultural barriers to comprehensive sexuality education?
Sorry, was that for,
you can both answer.
Okay, Lemessa, you go first, I'll come in.
Yeah.
In our case, the comprehensive sexuality education is not well accepted as a program actually, but there are a lot of initiatives. But the way we approach it, not by the comprehensive sexuality education so far, it is just women's health or the contraception and the comprehensive approach rather than actually explicit comprehensive sexuality education. That's why they address the other aspect of the women's health also in the village, and then they provide and they offer contraceptive choices if they need. It's not actually based on the programmatic aspect. It's not well established actually as a program at the school level. So, thank you.
I put a little bit of an answer in the Q&A actually a little bit. Someone asked me that question, and I think that part of it was actually making sure that we explained to parents, particularly what comprehensive sexuality education is, and that it's not sex lessons for 5-year-olds, and that actually it keeps children safe from abuse, from exploitation. So putting it in a sort of safeguarding safety zone actually got more parents, I think, engaged and on board with that. And I think certainly in the UK, it was the kind of recognition that with the internet, you know, young people are not protected from information, and what they will search out or be sent themselves by other people will be things that you would not want them to see. So actually having really good comprehensive sexuality education in school with trained professionals supported by parents is much more likely to keep children and young people safe. So I think the internet was a pivotal point for us actually. And in Parliament, we had very, very small numbers of parliamentarians opposing the legislation or the detailed guidance that was being issued to schools. So I think that was a sign that things had moved on. But there is still opposition there, undoubtedly, but it's more now around gender identity, inclusive CSE, trans issues than it is around sexual activity and hastening young people into sexual activity. So the issues have changed, but there is still an anti-CSE lobby very active.
Thank you both of you for your answers. And before we move on to the next case study, I would like to invite Nandita from the IBP to give a short comment and statement to what we've heard so far. Nandita, welcome.
Hi, thank you.
Maybe just in a nutshell, explain us a bit, who is IBP?
Sure. Well, thank you everyone for allowing me this platform and for the excellent presentations. I think certainly a lot to learn and be proud of. IBP Network is a network of over 100 NGO civil society organizations, as well as 20,000 individuals working in sexual and reproductive health and rights. We are housed at WHO in the Department of Sexual and Reproductive Health. And our mission is really to promote the dissemination and use of evidence-based guidelines, research results, other tools to help support SRHR efforts around the world. But we also foster collaboration and partnership. And that's really important for IBP, because what we've learned is that supporting dissemination and use is important, but what's equally important is hearing from countries on what research agendas should be set, what guidelines are needed, etc. And so it's really that two-way communication that we help to foster. I think one thing I will say, I don't want to take away too much time from the next set of panelists, but hearing the two presentations already, I think one thing we've learned is that the importance of sharing really can highlight the need for new partnerships. And we heard about the multi-sectoral way that England tackled this challenge, that relying only on the health sector wasn't enough. And I think that's a really important lesson learned that we can all learn. And similarly from Ethiopia, this priority on local needs was also very much highlighted, and another important lesson learned that, again, we through the IBP want to help promote through our work. The last thing I'll say is that in terms of sharing and fostering this collaboration, I would love to sort of hear how some of this effort can be shared more widely, and when we're happy to help promote through our network as we move forward. Thanks.
Thank you, Nandita, for your remarks. That is wonderful. And thanks so much for also co-hosting this event. That was wonderful. because we had over 500 people registering for this webinar. So we are really, really pleased to be able to share this so widely and having so many people taking part. I would like to move on to Fernando. I would like to invite Chile to the table. And we would love to hear from you, Fernando Gonzalez, the Director of the Department of Prevention and Disease Control from the Ministry of Health in Chile.
Thank you very much, Karin. Nice to see you, to share with you today this experience of Chile, the successful national government-led.
Second, Fernando, there is a background noise. Maybe you need to close the door or something.
Okay, sorry. Okay, it's okay now?
It's wonderful, Fernando. Go ahead, please.
Thank you, Chandra. May I share my presentation because I have a little changes, last minute changes. Is okay with that?
Yes, but you will need to be co-hosted or something like that.
Yes, please. Thank you very much.
Could you do that, Karin? He would like to share his own slides.
Here is okay for me.
Okay, go ahead. Great.
Thank you. Okay, well, thank you very much again for the invitation. My name is Fernando Gonzalez, and I will share today with you the successful national government-led large-scale and sustained adolescent pregnancy childbearing prevention programs of our country. Very quick, I have to share with you that our population in our country is of 19 million inhabitants in our country, in which 12%, almost 13% is adolescent population. A slightly skew in favor of males, and 80% of the adolescent population is beneficiary of the public health system. It's very difficult to classify our adolescents, but we can say that they are very, very diverse in its composition. The needs of sexually active adolescents differ from those from who are not sexually active to those that they are. Even among sexually active adolescents, some are really sexually active by choice, while some others are sexually active but not by choice. So this is the very diverse kind of adolescents that we have in our country. In terms of sexual and reproductive health in adolescents, we have a law that sets standards on information, guidance, and benefits in terms of fertility regulation. This law says that every person has the right to receive education, information, and guidance on the regulation of fertility in a clear, understandable, and complete, and where appropriate, confident manner. This law also sets the compulsory of the state to give emergency contraception to everyone who asks. So this is one of the most important actions that we've made in the last 10 years. And this, even though this we have this law, the average age of sexual initiation is still around the 16 years old, and this is earlier in men and in adolescents with lower socioeconomic status, as you can see. But we have a success story to share with you. In the last 15, 17 years, we've made a reduction in 51% in the proportion of birth to mothers aged under 19 years old, and the change driven by reduction in fertility in the ages 15 to 19. Here we can see the trends of the rates, and it's a very, it looks good, yes, and this is a consequence of some policies that I will share with you. What did Chile do for get these trends? Well, the strategies for reducing adolescent pregnancy and address vulnerable women were set off recognition of the problem, high adolescent fertility rates, and target 10% reduction in adolescent fertility as an aim. We strengthened the National Health Program for Adolescents by developing friendly spaces where adolescents could access to sexual and reproductive health and mental health services in a very friendly and closer way than the classical coverage of the public health system. And this augmented the access of this population. Also, we, as I told you before, we set the law that norms on information and services for fertility regulation. And in 2010 and in 2017, we changed the procedures for HIV exam in people under 18 years old. Also, in the same year, we began our law that permits abortion under 3 cases, particularly when there are violations or rapes, and when there are health involved of mother and inviability of the newborn. And the modification of norms to regulate fertility and strategy on sexual and reproductive health led our use of contraception in adolescents from the 17% to 25%. And here are the rates of use of different mechanisms of contraceptive method at last sexual intercourse in our adolescents. Of course, it's more prevalent in boys and in high socioeconomic status. What obstacles we find in the road? Well, cultural and social changes. The new laws, regulations, and programs require that parents and adolescents understand the problem and agree on the solution. Also, we have important obstacles in data. Information systems were required, and in many cases, these were not enough for accessing to all the cases, all adolescents and their trajectories. And finally, the advocacy was needed to overcome resistance to contraception provision. Sex education in schools was not pursued as a strategy to reduce the opposition, but we are working on that actually in this new administration of the state. And one very, very important obstacle that we're facing actually is currently is that we have a very, very very severe drop of 77% in pandemic after pandemic with the coverage of adolescent health controls. So we have to go to the communities, to the territories for to look and to recover the controls in this population. Now that we have not closed schools, we have all schools open and we don't have lockdowns. We have to go back and to rescale them. And to finish, in my last minute, I would want to share with you some challenges for the short and medium term. We should keep and reduce current pregnancy rates, particularly in women younger than 15 years old that are the most difficult to reach. We have to reach universal coverage in all the services of health and increase adolescent-specific health services such as friendly spaces, espacios amigables, health controls, and sexual and reproductive health counseling. Reduce geographical gaps, specifically with rural adolescents and youth people, and implement sex education courses in schools. The bond between health and education is something we have to work and strengthen in these years. And finally, increase post-pandemic coverages. As I told you, as I showed you recently, we have a very, very big and root work and task with that. So that's what I wanted to share with you. 8 minutes o'clock. Thank you very much.
Thank you so much, Fernando. There are already questions coming in, and I would like to address them later in the Q&A and listen first to Jamaica. And I would like to welcome Zoe Simpson, the Executive Director from Women's Center of Jamaica Foundation, to present on Jamaica and see how you are doing in your country and what kind of success stories do you have. The floor is yours, dear Zoe.
Thank you so much, Karine. The pleasure is mine to share with the world this morning in Jamaica, this success story of the government-led, government-birthed, government-supported program for adolescent mothers. The program actually started in 1978. The next slide will show, as the government responded to the 31%, the very high increase in the rate of adolescent pregnancy at the time. And as this slide shows, this graphic that shows us the embodiment of the program, which was the intervention, which provided the girls with the opportunity to continue their education during the period of their pregnancy. Then they are reintegrated into the formal school system, the school of choice, and we do that in collaboration with the Ministry of Education. We facilitate the girls by providing them with psychosocial and financial support when they are reintegrated. A research that was done much earlier showed that outside of this support, the chances are that the girls would drop out a second time. And we didn't want that at all. The aim then, the final strand there, is for them to complete their secondary education. Move it along for me, please, Chandra. Very good. Over the years, as the next slide shows, we would have therefore scaled up the program of intervention through specific strategies. The next slide, please, Chandra. And incrementally, we journeyed along with the program that constitutes academic instructions and group and individual counseling sessions and contraceptive methods. And by the way, we incorporated the parents as strategic stakeholders in the process of delivery of the program for adolescent mothers. And so the parents signed and gave consent to the institution for us to introduce the girls to contraceptive methods, for us to be counseling with them with respect to the options they had, the choices they would make. And the parents collaborated with us by taking their girls to the health center, signing for them to get a method and monitoring that process of the girls following up with their methods. Next slide, please. Over the years, in terms of the scale-up strategy, it was extensive and expansive and inclusive, so that we expanded the program. We started with one center in the city of Kingston, and then we incrementally increased the number of main centers and outreach stations. Today, we are in every parish in the island at 10 centers and 8 outreach stations. In other words, wherever the girls are, we have gone to introduce them to the program, purposes of affordability and accessibility, yes, and availability of the program to the girls wherever they are in the country. And then we have also done extensive public awareness campaigns and advocacy as we help to the nation on the whole to see that educating our girls comprised or would help us towards national development. So we showed the country how this paradigm now fits into the national development, the strategic goals of our country, to reduce poverty, to reduce gender-based violence, and to ensure that everyone is accounted for and provided for. The scale-up strategy also included a policy, the introduction of a policy for the reintegration of the school-age mothers into the school system. And the policy, therefore, ensured institutional commitment from all the ministries, from all the agencies, from all the NGOs and all the communities, and everybody recognizing that this is my responsibility to ensure that the girls return to school, their places remain in the school, they have a right to a solid education, and we must help them towards completion. So we had strong partnerships right across the sectors, several stakeholders, everybody joining hands, walking beside this program of intervention to ensure that all the girls went back to school and completed. The provision of support for transition to higher education, we recognized as well that a girl would have completed the program at say 17 or 18. She still needed to be assisted to take the next step towards higher education. And so we also provided that kind of a support through mentorship and sponsorships and scholarships. And this is what the government of Jamaica has been doing for the last 43 years. Next slide, please, as we continue to look at the scale-up strategy. This slide pretty much summarizes the process in 6 phases, from conception and piloting to getting the buy-in, the proof that this works and is something that we all should embrace, to the next phase over those period of years. There's national scale up, expansion, and introducing new concepts and new programs, designing programs to meet the needs as they arose at the time. And then the next phase to show the independent program expansion into different avenues. We included the young fathers as well. They are pretty much part and parcel of the paradigm, and so as not to leave anyone behind, we had programs that also included the young fathers. Not that we were advocating for the relationship between the girl and the father, but we recognized that the father had to support his child. The father had to play an integral role in the child's life. He had to also invest in himself. And so that's what we were looking at that phase primarily. And then we had sustainability and the policy change. I spoke a little bit about that already. So there is a policy in place that says the girl's space remains and she has a right to return to her school of origin or a school of choice. And we work closely with the Ministry of Education to ensure that each girl is reintegrated successfully into the formal school system. The 6th phase then is where we're at now, where we're looking to see how we can shore up and further scale up the program, especially in the pandemic, the period of the pandemic. The research is on in terms of the effects of the pandemic on the adolescent mother, the adolescent parent, and that's where we are looking to see how we can further account for everyone that is in that age cohort. So we had roadblocks like my sister countries. There was the social stigma and the discrimination that we had to hurdle and present the picture that yes, this girl is pregnant, but we must support her. Then we also had the cultural barriers. You know, with the thinking at the time was that a girl gets pregnant, she doesn't belong in school anymore. We had to hurdle that cultural barrier, mind you. And we had the hurdle of the absence of robust data gathering processes. We have successfully hurdled that challenge as well. And of course, the roadblock, as it relates to strategic monitoring and evaluation. So we asked the questions, what next? How else can we help our girls and our fathers? What else can we introduce into the program to ensure a fulsome intervention? The success stories, we will proudly speak about those. Recidivism has remained below 2% since inception. The increase in the percentage completing secondary education is something that we're very proud of. And that is the hallmark of the success of the program, the number of girls who complete. And we're happy for the increase. The reduction in the extent of discrimination, where the country is now recognizing all and sundry that we must address this program in a fulsome way, and we must do it together. So we're walking closer beside the girls and supporting them as they go back to school. The recognition as an international best practice. We're proud to say to the world that look at this model that has that is supported by the government, and it's something that you can also take and institute in your country. And I will proudly say that in the region, in the Caribbean, several countries have replicated the program for adolescent mothers in their country. We are the beneficiary of the 2018 UNESCO Prize for Girls and Women's Education, and we are delighted to report on that. The replication of the model in other territories, not just the Caribbean, but across the world, and we celebrate that success as well. Our next steps would be to increase the number of main centers and to therefore eliminate the outreach stations. The outreach stations are smaller versions of the main centers. What we want, therefore, is for equality and equity. So all the girls receiving the fulsome program of delivery even at a main center, and the government is committed to that as well. We are redesigning programs so that we can meet the needs of the older adolescent mothers, girls who will not necessarily be reintegrated, but girls who are now focusing on job readiness and entrepreneurship. We have a special program designed for that cohort of girls. We are completing and publishing a parenting curriculum that's designed specifically for adolescent parents, how to become a transformational parent. Yes, in this context. And we celebrate the fact that we are partnering with an international donor agency where that is concerned, and we're soon to publish. We are designing an equally robust program for the fathers as well. They must also recognize their contribution to their children's life and their own personal development. And that's what we're focusing on with a Young Fathers initiative sponsored by the government of Jamaica as well. We're seeking to acquire full registration status as an educational institution. And I share with you the take-home messages. The clarity in framing conceptualization of the program for adolescent mothers, underscored by credible indicators and evidences. That was an important catalyst for action. Then to the national government ownership. This is a national program owned and sponsored by the government. That's very important as well. And fidelity of implementation and retention of the core components of the PAM. We have to strengthen that. And that allowed for tracking the elements, for tracking improvements and impacts over time. The final set of messages we want to leave with you this morning, take-home messages. The PAM, the Program for Adolescent Mothers, as delivered by the Women's Center of Jamaica Foundation, represents a success model of conception, effectiveness, and scale-up of a program offering continuous education to pregnant girls, facilitating re-entry to secondary schools, and life skills programs to reduce repeat pregnancies. The PAM demonstrates the value of sustained cross-sectoral support, spearheaded or fully supported by the state in providing opportunities for vulnerable girls to redevelop their capabilities. And finally, while programs to prevent adolescent births in the first instance are crucial, several obstacles make this fully difficult. We recognize that, which justifies such interventions regardless of adolescent pregnancies. We thank you so much for having us this morning, and we're sure we stand ready to answer whatever questions you have about our program.
So can I request Fernando, Zoe, and Na to put on your videos so we can see you, and then you can engage in a discussion over the next 15 minutes with Karim.
Thank you so much for this wonderful presentation and insights. It's so beautiful to see that each country has their particular challenge, but at the same time, we're able to have so much progress, and we really hope to inspire many other countries to follow these examples and to keep trying to engage with the governments. I had a question first for you, Zoe. How did the strategy in Jamaica manage the potential stigma that may accompany girls who wanted to return to their previous school? You already mentioned how you were able to tackle the cultural norms and practices and were able to improve, but how did you do it?
Thank you for that question. I will gladly supply a response. The advocacy we were big on advocacy as we went across the length and breadth of Jamaica to secure the buy-in, the wide-scale buy-in from every person that we came upon. And the ministries and the departments and the agencies, the NGOs, the civil society, the church, the religious community, our message was that this is our responsibility. And we recognized as well that if the girls were going to be successful, then everybody had to be behind her. And the stigmatization that was rampant across the country, we had to ensure that that was reduced. What we found in particular, though, was that the parents and the girls embraced the concept that it was less expensive for the girl to return to her school of origin. In fact, she would have had her books, her uniforms, her friends, her teachers, kind of a thing, and so on. And if it is that they wanted to return to their school of origin, then the ministry facilitated that.
Thank you, Zoe. And Fernando, how is it in your country in Chile? I'm sure you also faced a lot of cultural barriers. How did you encounter it and what did you do about it?
Well, thank you for the question. I think the most important thing is to recognize and to meet the different kind of youths that we have in our country. In this sense, the youth-friendly health model in Chile makes it receptive to adolescents has been to take out the spaces out of the clinics and put them extra walls, locate them in squares, parks, and public spaces with games and comfortable spaces, and design with them these spaces. Well, likewise, in these spaces, there are health professionals trained to talk, consult, and guide in matters of sexual and reproductive health, establishing a bond built on trust with them. So I think that's the key of our policy.
Yeah. And how do you engage with the parents? Because teenage pregnancy is, they're not a single group. You also need to include the parents. So how do you engage with the parents?
Talking with young people, if they want and in which way they want to engage parents in this conversation. We have to talk to them, and after that we get the formula of including parents and carers in this conversation.
And how about you, Zoe?
From inception, from the intake interview, we had it was mandated that the parents accompany the girl for registration. And so we had that initial conversation with the parent to say, if your daughter is going to be successful, if she's going to rise above the challenges of this first pregnancy, if she's going to maximize potential, the onus is on you as her parent to walk beside her, to support her for the distance. So when she returns to school, you have to be there beside her. You have to ensure that she does her contraceptive methods, even that kind of a thing. But I wanted to insert as well that we included the student population as well, for them to get a better understanding of adolescent pregnancy and how they too can contribute to the successful completion of secondary for their peers. So we are finding that the students are also supportive of the girls when they return to school and ensuring an enabling environment.
Thank you. One more question for both of you, because we haven't tackled it so much. What about the fathers? Because we talk about teenage pregnancy, we mainly addressed the young women, but what about the fathers? What about the father of the teenagers? Not the teenagers, the baby of the teenagers. How do you work with them, or what did you do with them?
So if I may go first, then thank you so much. That's a very good question. I'd like to share a little bit about. It's a little challenging in Jamaica for us to reach the fathers and to have a robust intervention with them at the moment. Once upon a time, we did have a program of sorts, and we had to scale down on that even because of the punitive aspect of this matter, where, having sex with a minor is a sexual offense. And so it's challenging, therefore. But what we're saying to the fathers is that we're not so much after the punitive, whereas other agencies are reporting and are taking care of that. We want to help you as a father to become a better father for your child. And so that is the line in that is now guaranteeing us the buy-in from the fathers. And as we now continue with the government to institute or reinstitute a young fathers program that tends towards education and personal development and skills training and counseling, in-depth counseling in terms of how to be a father, how to deal with your own father issues that you might have had as a child yourself, and ensuring now that your child also has a fulsome support from the father. So we are going after a more robust program for adolescent fathers. And to date, I can say it is working very well because, again, the government has bought into this as we pay attention, not just to the girls, but also to the fathers of those babies.
How about you, Fernando? What do you do?
Well, I have to disclaim first that a significant number of pregnancies are unplanned, yes, but we must identify those that are planned. So, or in between a relationship. So we have to identify them, and we have to be capable of use those assets for the benefit of the development and loving and sensitive care of the newborn. But the other thing that's very important, what they are not planned, but in a relationship, we have to work with that couple with contraceptive methods, because we know that when there's an unplanned pregnancy, the risk of having another one is very, very high. So we have to work with them specifically on engaging them and giving them the tools for planifying their future offspring.
Thank you. Now I would like to have another special guest on this panel. I would like to invite Na Dodo. She's a senior research and policy analyst from African Institute for Policy and Development. Please tell us a bit more about Exemplars, which you belong to, and why is documenting and sharing outstanding case examples so important, and what do you do in this area?
Okay. So first of all, thank you so much for having me, and I've been really excited as I have listened to all the speakers, different kinds of countries, different kinds of contexts, all achieving the same thing, success with reduction in teenage pregnancies. Particularly because I'm involved in a project under the Exemplars set of initiatives that is dealing with exactly that. So first, let me say what the Exemplars in global health is. So it's an initiative that brings together experts, funders, and collaborators from around the globe to identify positive global health outlier countries on different topics, understand what has made those countries so successful, and then help others put these lessons into action. So at the moment, for example, there are different projects looking at child health, nutrition, COVID-19 response, primary healthcare systems, and women's health. And so it's really exciting to see all of these great examples. Thank you.
Thank you, Na. I have another special guest who would like to give a comment to what we heard about today, and this is Boris. Boris is a Women Deliver Young Leader alumnus and also a panel physician providing medical care and evacuation services to migrants and refugees in sub-Saharan Africa. He will talk about his country in Nigeria. So I will try to give you the floor, and you have to unmute yourself. I'm not sure whether I can, and then you can go ahead. But I can't unmute you. You are muted at the moment, Boris.
All right, can you hear me now?
I hear you. Welcome.
Thank you so much. My name is Boris.
Boris, can we see you? We'd like to see a handsome young man.
I think this is not possible because he comes from the audience. Sorry.
Okay, go ahead.
Great.
Go ahead, Boris.
Oh, thank you. So the government of Nigeria must enforce laws that it has made to protect child rights and must make adequate protections, budgetary provisions to cater for adolescent health and the universal basic education in Nigeria. It includes setting up special courts to try sexual offenders and also other cases related to child rights, and also expanding access to comprehensive sexuality education, contraception, and safe abortion. My first encounter with adolescent pregnancy is a true life story. I just started my clinical internship after medical school when I came across a 14-year-old girl with twin gestation in Nigeria. She was a victim of rape, school dropout, and ostracized by her family. Supported by her aunt, she was regular for antenatal care, but declined cesarean section on account of financial constraints. The hospital social welfare unit was overburdened and could not help much. Close to her expected date of delivery, she was rushed into the emergency ward with imminent signs of labor. There was no fetal heart sound heard. Although the doctors and the nurses took her to the operating room for an emergency cesarean section, she had bled profusely before presenting to the hospital. This child was slowly losing her consciousness on the operating table. We actually lost her before knife on came. This lost child lost our children. Everyone has a duty to end adolescent pregnancies. The risk and the health consequences are too much of a burden to allow to continue in our generation. We must take a stand and we must put all hands on deck to stop this tide. Thank you.
Thank you very much, Boris, to step in and talk about your country. And it's always wonderful to have Women Deliver taking part. We are coming more and more to the end of this wonderful session, and I would like to hand over to Chandra and thank him so much for being able to organize that this event together with you, Chandra. And I also like to hand over to Laura. Welcome, Laura and Chandra, for the final remarks and also for the take-home messages from this webinar. Thank you.
In this last session, Laura Giron and I are going to try to bring some of the threads of this discussion together. Alison, Lemessa, Fernando, and Zoe, please stay on, because we may ask you to come in with one last message that you might give to a government or a funding agency which is beginning to move in this area. But why don't you begin, Laura? You have been one of the central members of ExpandNet. You're going to say a little bit about ExpandNet. I've worked with you and with the ExpandNet Secretariat for many years now, learned a lot from and with you. So a little bit about ExpandNet, a little bit about scaling up, but just a little bit to inform people and give them a link, because I want to get back to you. What are your takeaways from each of these countries? What I want you to do, please, Laura, is what is your one takeaway message from England, from Ethiopia, from Chile, and from Jamaica? Something that someone like you who has worked for many years in scale up said, wow, that's interesting.
Yeah.
Over to you, Laura.
Great. Thank you, Chandra, and everybody. I so appreciate being here. So let me start by telling everyone about ExpandNet, because it may be of interest to many on the call. So ExpandNet is an informal global network, mainly of public health and development professionals, and we're all working on advancing both the science and the practice of scaling up. And by scaling up, we mean taking something that is known to work and expanding it to reach more people and to become part of policies and programs. So ExpandNet has been led since its founding in 2003 by a small secretariat and with leadership from WHO, Chandra, Peter Fyans, many others. And back then, which was quite a while ago now, many of us from different countries were identifying that there was a knowledge and practice gap around what made scaling up successful. And it was figuring that gap out that set us on a journey to try to bridge it. And so together with WHO, we prepared initially a book of case studies from countries, and then subsequently several guidance tools in response to requests from countries and the field to help people with the scaling up process, from the very beginning of piloting something to managing the scaling up process. So in addition to the guidance tools that we developed and have been using with different countries, we began providing technical support on the scaling up tasks because people really benefited, they felt, from having some mentoring and guidance. So since we have been working with WHO and different donors and NGO partners to build the wider field of Scale Up, one of the things that we've been doing in addition is helping to lead communities of practice around scaling up so that, like this webinar, we can share learning about what makes scaling up succeed. And I'll just put in a little plug that everyone is invited to join our health working group of the larger community of practice on scaling up development outcomes, which is a multi-sectoral learning network. And of course, we heard today that a lot of these initiatives that were successful because of spanning different sectors. And I think that's an important comparative analysis that we all can work on together. So to be added, just reach us through the expandnet.net website. And then I just wanted to say, looking forward, ExpandNet is planning to develop what we're calling a scale-up learning center, because we want to make the learning from ExpandNet, of course, ExpandNet WHO have published guides, but we want to give people more of access to a curriculum and to gain learning opportunities exactly like what we had today. And so we're going to launch the Scale Up Learning Center in early 2023. And there'll be different tracks that people can follow, or of course it's all open source like all of our resources. So we hope you'll stick with us on that. But now I really want to turn to what Chandra is asking of me.
What I'd like you to do, Laura, because we have only 7 minutes and people are dropping out, and I want you to keep them there. So from England, what's the one message you took away? And Alison, after she speaks about England, I want you to turn on your camera and say something about one message to other countries who are on this journey. Okay, Laura, you can begin.
Okay, so with England, but really all of the cases, honestly, Chandra and team, the fact of the strategic and coordinated government action, multi-sectoral, multi-agency action that was required to accomplish what was done in England was just incredible. And this is exactly what we all recognize is needed, this measure of political will, this galvanizing of the different agencies coming around a common goal. It was incredible. And,
thank you, Laura.
And yeah,
Alison,
go ahead.
Alison,
okay.
If you were going to get countries to do that, what's the one obstacle that they need to overcome?
I think it's persuading.
Just a minute, Alison.
Yeah.
Now, can you get ready to pose to think of a point for Lemessa, and then Nandita for Fernando? Okay.
Excellent
over
choreography,
to you,
Chandra. I think it's the advocacy to help people understand at the highest level that success benefits everyone. It benefits education, it benefits health, it benefits employment, it benefits the economy. And the second message is it can be done. In England, there were people who said, England always has high rates, we'll never do anything about it. And we showed them that that was not the case. So I think it benefits everyone. It saves money. If you have to look at it economically, it saves money, including support for young parents, and it's achievable. And we've learned today of how many lessons there are that we can share between us.
Thank you, Alison. You've become a good friend, and we have gone around the world selling that these messages, that it can be done and is being done. Now, what's the one message from Lemesa's presentation that struck you?
I think that the one message that struck me out of so many is that availability of services targeted to adolescents can really achieve great success, so that they are doing so much better even than adults. If you look at, for example, the rates of safe abortion and all, and I think that was really, really great. Yes.
Wonderful. Lemesa, what did it take to do that in a country which was recovering from many years of civil war and famine? And how did they achieve this openness to liberalizing the abortion law?
It was not simple, actually. It was through advocacy of professional associations and advocacy of women group. So it is just making on board everybody actually have a stake in ensuring adolescent and the women's health. So abortion is not legal actually in Ethiopia, but liberalized. There is a liberalized abortion. So that, what does that mean? There should be conditions that should be fulfilled actually, that condition on which physicians who should say, this is a therapeutic component of what? Treated abortion or unsafe abortion or already abortion, inevitable abortion. So that is how it is said, but it is not boldly said legal. So that is liberalization.
Thank you for that important correction. Now, if you were advising another country to do this, what is the one message you would give them?
Is it me again?
Yes, it's you. Yes. You again, Lemesa. We won't let you go so easily.
Yeah, thank you very much. Yeah, what we need to do is just to ensure ownership of professionals, on making on board professional groups, communities, and also the target population at large own the program at local context. So if they work together, everything is achievable, actually. If it is uplifted and only discussed at higher level alone, it will not be successful. So bring down to the beneficiary side. Thank
Fully
you.
taken. Over to you, Nandita. I mean, like Nandita, like you, all of us were blown away by Fernando and this, new government that he represents in Chile, a young, progressive government, female-friendly government. We are looking to so much to you and your country, Fernando. So can you ask Fernando a hard question? He's got a satisfied look on his face. Give him a tough question.
Oh, okay. You want me to give him a question? Well, I think what I found so impressive was that grounding this approach in the 10-year national strategy has really been impactful, because irrespective of administration, the progress is able to be made. And I'd like to know what's the next step? How do you ensure that sustains beyond? I think that's one of the biggest challenges in a lot of this work with Scale Up, is ensuring that it sustains beyond 5 years, 10 years, beyond administration. So that would be my question for you, Fernando.
Thank you. And can I add a rider, Fernando? You mentioned about reaching 10 to 14-year-olds, the very young pregnancies. So can you talk about sustaining, and can you also talk about, statutory rape when 10 to 14-year-olds get pregnant? So how do you deal with that?
Thank you, Chandra. Thank you, Nandita. In 1 minute only? Oh my God. Okay. Well, the most important thing is to put young people on the center, listen to them. It's an explicit right on the Convention of the Rights of the Child, and it was sung in the 90s. Yes, they are the world in their own agency role. Ask them for the question that we already assume that we have answered de facto. And they have the answers to our cultural gaps, specifically the youngest one, yes, as you asked, Chandra. Probably with the creation of binding participation spaces, they will give us the correct answers to that great and challenging questions. And specifically the same with the new understanding of sexuality, which we adults are slow to understand. New forms of links, affections, and the value of sexuality. It's different. We must recognize the gaps, this great gap, understand that dimension by listening them, opening spaces of safety, secure spaces, and understand the new phases of sexuality in the youth. Thank you.
Thank you. 10 to 14-year-olds.
Sorry?
The 10 to 14-year-olds.
10 to 14-year-olds, we have to listen to them. We have, because the participating spaces are always captured by
we can find solutions through them.
And yes, and because they are in a very sensible window of time that they are knowing and understanding the world. So if we go with them, understanding their conceptions and sharing with them the decisions, I think that's the key answer to the question.
Thank you, Fernando. Laura, the last point to Zoe. You know, what's the one thing that you were blown away with Zoe's presentation? And then after Zoe's response, I'm going to conclude with 3 small points and let you go for a cup of tea or coffee or whatever you want. Over to you, Laura.
Well, Zoe's presentation was remarkable in the sense that they were able to just cover the entire island with just a blanket. And I think that this is a challenge for some countries. Maybe Jamaica's size really added, but the unity and the credibility across all of these different stakeholder groups was so striking. And I want to read more about what happened in Jamaica. Thank you, Zoe.
We've just published a paper. A paper is just about to be published in the American Journal of Sexuality Education. Joshua Amuadjai is the lead author. Joshua, if you're on the call, put your email address. You'll get lots of fans. Go on, Zoe. Respond to that, please.
Right. And so for us to have achieved that extent of support across Ireland even, the message we sent was no. We say no to discrimination and stigmatization, and we say yes to education for all adolescent mothers in our country. Hence, the extent of the budgetary support that we received and we continue to receive to ensure that all the girls receive a solid education and are positioned to maximize their potential. We are grateful for the extensive support that we've been getting from all the ministries, all the agencies, from civil society Jamaica, and that's what has resulted in this extent of success of the program.
Thank you, Zoe. I'd like to close with one message to you all. I'm often in meetings when they talk about adolescent sexual and reproductive health. And most of the time in these meetings, the messages, the words used are difficult, hard to reach, difficult to address, difficult to achieve results. This webinar, with 4 country examples from 4 different parts of the world, has told you that's nonsense. The first point is, we know what to do. We know what to do. Countries know what to do. Countries are doing it. Jamaica has been doing it for 43 years. That's point number 1. Second is, we cannot do it. We can do it at the size of a project, but we can't do it at the size of a country. Again, you know, for the last 10 years, I've stopped documenting small projects. We need Ethiopia, we need Jamaica, we need England, countries that can show that this is doable. It's doable if governments want to get it done. It's not doable if governments want to twitter around the edges and make speeches and give $5,000 there and $5,000 there. The last point is, we don't have resources. All these countries put resources of their own. Jamaica is not a very rich country. They asked the women's program to show proof of principle in 1 year. And once they showed proof of principle, they invested in it because, like Alison said, they saw a wider benefit. And I think if countries put money on the table, funders will put money on the table, internal funders and external funders. We cannot develop plans and then wait for donors to come in with our bags open for them to come in and drop their money in. So that's my message. We know what to do, and we are learning and getting better, but we know what to do. It is doable. And there are resources in countries. And if there are resources in countries, resources will come from outside, as Ethiopia was able to show with its health extension program. So namaste. And thank you all. We are grateful to you for making the time to participate in this webinar, and we look forward to continued engagement. My grateful thanks to Alison, to Lemessa, to Fernando, to Zoe, to Laura, to Nandita, to Na, and to Karine, to all of you for a wonderful afternoon.